Welcome to the opioid epidemic, our businesses, and our workplaces. Thank you very much for coming out this morning. I know it's going to be snowing later, but right now we're in a safe zone, so hopefully we'll be out of here before any serious weather. My name is Jeff Stone. I'm with the North Suffolk Public Health Collaborative. And I think we're all here today because we know that each of us in this room has a role to play in ending the opioid overdose epidemic. At his State of the State speech, Governor Baker talked about the tremendous efforts of the administration, the legislature, and people across the Commonwealth on this issue. But he said, and I quote, he said, "We need to do more." And he emphasized that. And I'm sure our Secretary Sutters will talk more about that in a moment. So I want to thank very much the three chambers of commerce from Revere, Chelsea, and Winthrop for jumping on this idea of presenting this kind of forum for their members and the whole community. I want to thank all of the speakers for generously giving up their time to be here today. I want to thank the Comfort Inn for making this so easy for us to do. Also want to acknowledge several people in the room, our elected officials, Mayor Brian Arrigo. Where's the mayor? The mayor is in that corner. Thank you, Mayor. City Manager Tom Ambrosino from Chelsea. I'm not sure if Town Manager Terry Delahanty is in the room. I don't think he is, but he's very supportive of this effort. We also have Revere City Councilor Patrick Keefe. Where are you, Patrick? Any other elected officials here? Okay. Some may be coming a little bit later. Before inviting the chamber leaders to come up here and say a few words, I just want to say that multi-sector coalitions are sort of the gold standard in community efforts to address and prevent substance use disorder. Businesses and all employers are key members of those multi-sector coalitions. They're key partners. So those of you who are businesses, representing businesses today, or those who work with businesses and other employers, you all have a role to play, a huge role. So I'd like to ask Bob, Rich, and Betsy, the chamber leaders, to come up and say a few words of greeting.
Thank you very much for coming out and supporting this initiative. We at the Revere Chamber of Commerce, we have members of our board of directors, Steve Miliotis and Karen Gallo, are here with us this morning. There are many other chamber members here this morning, to include East Boston Neighborhood Health, North Suffolk Mental Health, the CAPIC, North Suffolk Mental Health, as I said, East Boston Savings Bank. I see many other faces of members of the Chamber of Commerce. This is very important. The topic is very important and near and dear to our hearts. There's probably nobody in this room that isn't touched by the opioid epidemic or addiction in some way, shape, or form. We do appreciate this opportunity. We appreciate the Comfort Inn for being such gracious hosts and working with us as they have with most of the things that we do at the Chamber of Commerce. And we can rely on many of our members of this type of support. It's nice to work with Rich and nice to work with Betsy and Jeff. And again, we thank you very much for your attendance and input today. And thank you, Jeff.
You're welcome, Bob.
Good morning, everyone. I can't improve on what Bob said. So I just want to thank everybody for braving traffic and the snow that's about to come. One of the things we're going to try and do is get a digital video of today's presentation so we can get it out onto our websites, onto our YouTube channels. So if anybody wasn't here, couldn't be here, an HR director at a company that should have been here, we're going to have an avenue for them to see and hear what you're about to see and hear. Thank you.
Thank you, Rich. And Revere TV is taping this for broadcast and for uploading to YouTube later. Betsy Shane from Winthrop.
Thank you, Jeff. Thank you, everybody, for being here. Again, an important topic. We're just glad that we were able to be a part of it and to keep this conversation going in our communities. Our community has CASA as our coalition group that's on the floor, and it's really important that the businesses and the local coalitions also continue to work together in order to help try to solve this problem. I also just want to recognize Barbara Bishop, who's here not just as a Winthrop person, but representing the speaker and his office, and I just want to thank him and her for all the support that they give us in our community, and to CASA also in our community. So thanks for all being here, and we really appreciate it.
Thanks, Betsy. Okay, now I would like to introduce our keynote speaker, Secretary of the Massachusetts Office, Massachusetts Executive Office of Health and Human Services, Secretary Mary Lou Sutters, who has been at the forefront with the governor, with other administration officials in working to address the opioid epidemic. Secretary Sutters.
Good morning, everybody. Oh, come on. Good morning. Good morning. Thank you for having me this morning. I appreciate the brief introduction, because when usually somebody does my bio, it sounds like I'm either really old, I can't hold on to a job, or really, can't you stick with something? So first of all, I want to thank the communities for coming together, because it's going to take all of us to really bend the trend of opioid deaths in the Commonwealth of Massachusetts. I want to give a shout out to some of our first responders here today, police departments, because you've been on the front lines in many ways, engaging in saving lives, even before some of us in the medical world and others really have stepped up. So for me to not acknowledge what you do each and every day to help save lives in the Commonwealth would be remiss. So I just really want to thank you for that. So I want to talk to you to try to set a stage for why being together is so important. So I'm glad Jay Ash isn't here today. I do refer to him as my favorite one percenter, and because I'm responsible for 53% of the state budget, he's responsible for 1%. But I know how important he is to the community of Chelsea, and I know he did a lot of work actually trying to bring together Chelsea, Winthrop, and Revere when he was as the city manager, and we are lucky to have him as secretary in the governor's cabinet. I'm the governor's independent in his cabinet, and anybody who knows me would probably say that about me. I don't know why. I'm a social worker by training, and it's a privilege to be secretary. It's also extraordinarily humbling, because even with all the resources that I'm responsible to marshal for the 1 in 4 residents who touch directly some part of what I'm responsible for, you know that you can't correct everything that comes to you, every condition, you can't save every life at this moment, but you can treat people with dignity and respect, and we can find ways of coming together, particularly on the opioid epidemic. The governor gets elected. Everywhere he ran when he was running for governor, he didn't run on an opioid epidemic. He didn't really even know what that was, what all these pills were, except that everywhere he went, and someone, like a fundraiser or a community group, someone would take him aside and say, can I just talk to you about these pills? Can I just talk to you about my family member? And he's a healthcare guy, as I'm sure all you know. And he would talk to the heads of hospitals and the heads of other insurance companies and say, what is this? And they would say, well, it might be a problem, but it wasn't like an epidemic. It wasn't what the communities were feeling, what family members were feeling. So I was at Boston College School of Social Work for a couple of years, teaching health and mental health to social work students. And he asked me to put together to help him think about this a little bit. And I put together just a very small white paper for him as he was running for governor. I was doing my academic thing. Anybody running for governor at that point, I was like, do we need a white paper on mental health or addictions or child welfare? I'm happy to do that for you. And the governor realized that what families and communities were experiencing was being sort of missed in the medical and insurance world. I'm not saying that about Dr. Wally, who you're going to hear from, who is an expert in this field, because people who are in addictions and who are street workers and police and others, you were seeing it. Families were seeing it, but it was being missed. So fast forward, the governor becomes governor. He talks about it in his State of the State. He asked me to chair a working group. You can go on the mass.gov website, just type in opioids. You can pull down the governor's blueprint, the working group blueprint. It's a public health approach to the epidemic with strong connections to law enforcement. We framed addictions for what they are, a disease. It's not a lack of willpower. Addictions and mental illness are so stigmatized in our society. Mental illness runs in 3 generations of my family, not always with good outcomes. My mom died from a co-occurring illness, otherwise known as serious depression, completely missed by anyone, and she used alcohol to basically medicate her illness, and she died 4 days after her 40th birthday from cirrhosis. I was 15, and I took care of her for the last 6 months of her life. It took any interest I might have ever had in nursing, took care of that. Left me sort of angry about like why were doctors and people not seeing that my mom, who was once this lovely, vibrant, worked, involved in her church. She was the part-time church organist. Everyone wanted Lily's. My mother was an unbelievable baker. Everybody wanted Lily's baked goods at the church on Sunday after church, until she just started to really withdraw from life, and our living room became her bedroom for the last three months of her life. So I walked this walk. So here's where we are, and I tell you that just because I'm not ashamed of the fact that the illnesses run in my family. My job is to channel that adolescent anger, if you would, into a professional commitment to really treat addictions and mental illnesses the same way we want physical illnesses dealt with. We don't stigmatize people with other chronic kinds of conditions, medical illnesses, and we need to also have that conversation around addictions, and it's hard. Because so often people with addictions and mental illness, their way into treatment has been through the police and our criminal justice system. It's been a more open door for them to get into treatment than through our medical and mental health and substance use communities. So that's our job. So employers, this is what you need to think about. I need you to think about this. You will have employees who probably have addictions, active addictions, or on the path to addictions. You have people who work for you who have a family member who has addictions. And they may call in sick, or they go on vacation, but they're not really on vacation. They're out trying to find their family member to help get them into treatment. You need to sort of understand what you need to do to keep your employee or your businesses going, and to understand that we are in the middle of an epidemic in Massachusetts. And I don't say that to alarm you, but for all of us to start to have this conversation. So we're all in. I know I have 10 minutes to do a keynote, and then I'm running out the door because no one ever sees me anymore for very long. So this administration, this is not a one and done for us. Addictions and mental illness are a core tenet of this administration for however long Governor Baker has the confidence of the public to be governor. So it's not like a campaign speech and you like, okay, did that, a little money in the budget, a little bill passed or whatever. This is very core to us. We are expanding access to treatment. So for the first 2 years, is this helpful? I could sing and dance, but it won't be pretty. Trust me. So for the first 2 years of the administration, after the blueprint, after we put out this blueprint, which was unanimously agreed to by a large working group, which included, as you can imagine, people who believed that abstinence was the only form of treatment, to individuals who believed in medication-assisted treatment, and everything in between. Every once in a while, my rusty group work skills came in handy, keeping the group together. And we have been, for the first 2 years, really trying to expand access to treatment, expand community coalitions, expand Narcan, because Narcan saves lives. Narcan gives us the opportunity to try to then engage with someone. I am expanding access to medication-assisted treatment, detox beds, residential recovery beds, street workers, funding for community coalitions, you name it, we're trying to expand access to treatment. Over the next 5 years, through our Medicaid program, we will invest about $219 million in expanding residential recovery homes, medication-assisted treatment, recovery coaches as part of treatment teams. Street workers, like my good friend sitting over there, who told me he has his tuxedo outfit on today rather than a street work outfit. So we will be expanding that. But we also need to ensure that the people that we work with get access to treatment, and that the families, that we support them and not blame them for their family members. So please know that. We're in this with you. This is not just the governor. This is trying to work with communities, because the needs in Winthrop, Revere, and Chelsea may be different than what the needs are out in Camden County. So we're trying in government to support you and not say there's a one type of approach to meeting all of these needs. So thank you for being here. Thank you for your interest. Remember that addictions are also chronically relapsing. So it's important that when someone starts on a path to treatment, that they may relapse. Addictions are very powerful, very, very powerful. And I'm sure in this room, you have a family member, a loved one, a community member, someone that you know is struggling. There is some glimmer of hope. I'm very careful about how I talk about this. So we've been on this unbelievable trajectory. 6 people a day die in Massachusetts from an overdose. For the first 9 months of this calendar year, compared to the first 9 months of the prior calendar year, we've actually seen a slight decrease in opioid deaths, 10% decrease, and we've seen a significant decrease in the amount of prescriptions of opioids prescribed in Massachusetts. At that same time, we've seen a 200% increase in non-fatal overdoses, and an 87% increase in emergency room use, people being brought for an overdose. So the good news is, the glimmer of hope is that we're starting to see a trend in the bend of deaths, and I believe this next quarterly report that comes out from DPA will also continue to show a bend in the opioid death. But underneath that is still a whole lot of suffering and work that together we need to do. So thank you for being here. I'm grateful for your interest. I'm grateful for the connection between these 3 very close communities. You have strong legislative leadership, you have strong city leadership, and you have great community partners to bring this together. So I hope this is helpful as you set up. I'm just doing the setup for the wonderful Dr. Wally, who will take you through with much more detail. But please know you can always reach me. I actually respond to all my emails. I'm a little slower than I used to be before I was secretary. But if there's anything we can do, if you run into like state bumps, which on occasion, I give out a grant to a community apparently and can't quite share with the next community over, we're very good at removing those kinds of barriers. So please know that. So have a great day together. We're in New England. Who cares if it really snows or not? I have the shovel in my car. And most important, thank you for caring. Because it's by really being all together that we actually will truly bend the trend of opioid death to come off and help people find paths to recovery. So thank you.
Thank you very much. Secretary Sutters, we really appreciate you being with us and the support of the state for all these community efforts and multi-sector community efforts and community clusters through the MOPSI and SAPSI and other grant programs which we didn't mention. Thank you very much. Now I'd like to invite Dr. Alex Wally to come up and speak. Dr. Wally, you can sit or you can stand. I have your PowerPoint queued up. You can just point when you want the next slide. And Dr. Wally has a long resume, and he said don't read it, so I'm just going to say assistant professor at the Boston University School of Medicine and many, many titles in addiction medicine, and we're lucky to have him today.
So I'm really happy to be here. In fact, I was just talking to the secretary and Chris Alba about how this is the first time I've had the opportunity to speak in front of businesses, and I think that's quite remarkable. So I want to really celebrate the fact that you all have taken this issue on and that you've shown up today to talk about it, because we really, businesses are also on the front lines, just like first responders and healthcare workers. I know not just in these three communities, but throughout Massachusetts, people are faced with this in their own families, with their employees, with their customers, in their public spaces that they manage. I haven't had the chance to talk to a group like this before. I'm excited. I'm especially interested in the question and answer period. Jeff wants me to cover a lot in 15 minutes. So I'm going to do my best to do that. I will just say a little bit that I see patients. I'm a primary care doctor at Boston Medical Center, where I specifically focus on patients with HIV. I could talk for an hour about the lessons that we can learn from the HIV epidemic and how we could apply those to addiction. I also see patients at a methadone maintenance program. I've worked initially at Boston had a city methadone program where I saw patients. I feel fortunate. I do get to work with the Massachusetts Department of Public Health on overdose prevention. I do a lot of naloxone or Narcan work, and then I also do some research. Next slide. So here's what I'm going to talk about. Opioid use disorder is a chronic relapsing brain condition. The secretary, I think, sort of mentioned that very eloquently. And so this is going to be some repetition from what you heard from her, with probably a little bit more data geek in it. Treatment works and people recover, so that's an important message. She already made the biggest step, I think, around stigma and addiction by talking about her own personal experience. And I think that is really goes a long way to dealing with stigma. I'm going to give you some specific terms to think about. I'll show you a little bit on how this impacts on the workplace, although I think it'd be more interesting to hear from you all how it's impacting on the workplace. And then people in recovery can be great employees, and employers can help. So that's going to be it in about the next 10 minutes. Next slide. Okay, so first some data. Okay, this is comes from the headlines from December 21st, 2017, and it's remarkable. This is one of the headlines: opioid crisis linked to 2-year drop in U.S. life expectancy. It hasn't been since a very long time ago that the U.S. life expectancy has decreased in 2 successive years. This is from the CDC, and it shows you the major causes of death. Not surprisingly, number 1 is heart disease. We have improved, as we have every year, in the mortality of heart disease. This blue line is longer than the green line, and so the green line is progress in 2016. The next most common cause of death is cancer. And again, you see how this line's getting better. And all of these other lines are getting better, except for unintentional injuries. And this is looks small on this slide, but it's a large increase in the number of unintentional injuries. What's the biggest contributor to unintentional injuries now? Overdose. What's the biggest contributor to overdose? It's opioids. So that's where we're seeing this 2-year drop. It's attributable to the unintentional injuries. So you can see a lot of the other common conditions that we think of, right, that are causes of death in our communities. I'll just point out 2 other things, again, echoing what the secretary was saying. The 2 other areas that actually went up. One is Alzheimer's disease, which doesn't actually have an addiction connection, but it's a disease of the brain that we're seeing with our aging population, and something that we need to think about more and more from a public health side. And the other one is actually suicide. Okay, and so suicides have gone up. Again, not like the same margin with unintentional injuries, but they've gone up. So if you look at all of these diseases, there's an addiction contribution to many of them. So tobacco and alcohol contributes to heart disease, alcohol, tobacco, and hepatitis C, which is often related to opioid use or injection, causes many of the cancers, chronic lower respiratory diseases, again, smoking, and so on and so forth. So addiction is contributing to a lot of these causes, and this means we really, this is, if you're going to focus on what's helping people live longer or what's killing people, I think the opioid crisis is something now that has come to the forefront. Okay, so next slide. Okay, so you heard this already. Opioid use disorder is chronic. It's a relapsing condition of the brain, and that it's treatable. So next click, maybe we'll see. Okay, so here I have a figure from Norway, actually, for people on methadone. But this actually is true for all forms of treatment when they're on it. So you could put buprenorphine, you could put naltrexone there, you could put even residential treatment there. Overdose deaths per 100 person years. Okay, so this is the number of overdose deaths. When people are on a treatment waiting list, they have a high overdose death rate. When they get treated, they have a four times decrease, or fourfold decrease in their number of overdoses. And then when we take them off of treatment, the overdoses go back up. What this pattern tells us, the good news is that opioid use disorder is treatable. The bad news is it's not curable. If it were curable, right, then this line would be down. Once you go off treatment, your overdose deaths are going to go right back up. Okay, so that's really an important concept, I think. For people with severe opioid use disorder, it's really, we don't have treatments that cure it at this point. And it's similar, the problem with residential treatment is that when people go to residential treatment, they don't overdose, they do get better. But eventually people have to go home, right? And so if you give them residential treatment and don't give them something else, then their overdose rates are going to go back up, okay? And the same is true with, with medications, with counseling, etc. Okay, so let's go to the next slide and click again. So diabetes is a chronic, click again for me, is a chronic relapsing condition not of the brain but of the pancreas that is treatable. So here we're looking at insulin, but you could also read all the other treatments for diabetes. The hemoglobin A1C is our marker for disease severity. It's high before you get treated for your diabetes. During treatment, it goes down, and if we take you off your treatment for your diabetes, it goes right back up again, okay? So it's very similar to opioid use disorder. Next slide. Asthma is a chronic relapsing condition of the lungs that is treatable. Okay, so now we're looking at emergency department visits per year. Before you get treated for your asthma on a chronic treatment, you're going to go to the emergency department a lot. When you get treated, you go to the emergency department less. If we stop your treatment, you're going back to the emergency department. There's lots of other outcomes that we could look at for all of these conditions, okay? So chronic relapsing condition that is treatable. This is what the majority of what our healthcare is right now, and opioid use disorder fits right into that paradigm. Next slide. Okay, addiction is different, okay? So we call it a disease, but it's different really because of, one major reason it's different is because of the stigma that we have loaded into it, okay? Another big reason, though, is that, I think it's a natural question, why can't he just stop? Or why can't they just stop using, right? Because I don't use drugs compulsively. I don't have cravings. And if I do use a substance, whether it's alcohol or opioids, and I have an adverse consequence, I learn from that and I don't use it again, right? So that's sort of normal, logical, like the way the human brain, we expect it to work, right? But the problem is that addiction in its core is a disease of craving, compulsive use, and despite adverse consequences is literally in the definition of addiction. So we ask, why can't he just stop? It's like a circular argument. Why he can't just stop is because he has an addiction. The addiction itself is use despite adverse consequences. If addiction didn't have that use despite adverse consequences, it wouldn't be an addiction. People would learn and they wouldn't use anymore. So this is where the brain disease part is really crucial and how it's a little bit different from other diseases or chronic diseases. The treatment and the paradigm is similar, but But this is, and I think this is a particularly frustrating piece of it for those who don't have addictions themselves to really understand how they can't get past it. Okay, next slide. Okay, so this doesn't project well enough, so I'm going to have to read it. So stigma, so words matter. Again, I really think that the secretary kind of hit the nail on the head with this. But there is evidence that shows that what we say and how we say it makes a difference to our patients. Now I'm talking really about healthcare workers, but it's true about, I think, everybody, to patients with a substance use disorder. So actually, work done out of Mass General showed that providers treat people differently if the patient described to them is described with different words. And so the ones that are specifically been studied are addict and abuser. Okay, we want to get rid of those stigmatizing terms and replace them with person-first language. A person with a substance use disorder is a better term than a substance abuser, an alcoholic, an addict, a user, an abuser, a drunk, or a junkie. All of those terms reduce the person to their behavior and ignores that they are a person first. So that's why we say person-first language. And by the way, terms like diabetic, asthmatic, and schizophrenic are exactly the same as addict. We really shouldn't be referring to people with diabetes as diabetics. They're more than their disease. Or schizophrenic, as you know, they're more than their disease. They're a person with schizophrenia. And so that's one place we can start. Other terms, substance use disorder or addiction, use and misuse, risk, unhealthy, or heavy use, all describe the behavior or the clinical condition. That's really what's most useful. Drug habit, abuse, and a problem, those are more, they're judgmental terms. They're loaded with judgment, okay? And that judgment gets placed onto the person themselves, and it's really not helpful in their recovery. People are already judging themselves enough to have outsiders judge them. That's usually not the motivation that they need to get better. Okay, so there's also this issue of clean and dirty, which, it's common parlance, I think, in the recovery community, but in the clinical world, we're really trying to get away from describing people or their specimens are clean and dirty and use more precise terms like positive or negative toxicology, and describing what the results of a drug test are, for example. One that's really tricky, where I think, medication-assisted treatment is the term that I think is really now in common parlance. To go with this stigmatizing language all the way, to sort of the cutting edge, I would say, we're trying to shift that to medication for addiction treatment. Because the idea here is that medication-assisted treatment, the medication's assisting other treatment. We would argue, just like with diabetes, insulin is the treatment, along with counseling and weight loss, etc. It's on the same level, and we think that medication is for opioid use disorder. Okay, next slide. So economic impact of the, so if the stigma argument doesn't get you, or if the life-saving elements of the condition don't get you, the economics really should. The White House Council of Economic Advisors in November released a report, The Underestimated Cost of the Opioid Crisis. So they actually reanalyzed other economic analyses of the opioid crisis and revised their numbers upward. So the economic costs yearly are $404 billion, or 2.8% of the gross domestic product. 73% of these costs are attributed to the non-fatal consequences, including healthcare spending, criminal justice, and lost productivity at work due to addiction and incarceration. 27% is attributed to the potential earnings, lost potential earnings due to death. So this is a major economic drain on our economy right now. Not to mention all the sadness and heartache and health problems that come with it. Princeton economist Alan Kruger suggested that the epidemic accounts for a 20% decline in labor force participation among men. So, this is a wide-ranging problem that's really affecting you could even argue our national security. Next slide. So this is a tool that you can use if you're an employer, the National Safety Council Calculator. I put the website up there. They had a project called The Real Costs of Substance Use in Your Workforce, a substance use cost calculator for employers. And this is the cost. For Boston Medical Center, we plugged in our numbers, and this is what we got. The total cost of substance use for Boston Medical Center from the drain from the workforce is $1,926,000. I'll just read this because it's hard to read. This report combines the latest research on employment costs with data from the National Survey on Drug Use and Health to calculate how much substance use in your workforce costs employers annually. Okay, so how can employers respond to the epidemic? Mass Health Council flyer that I got walking in here, this just reiterates those 7 points, okay? So this is what you can do as employers. So if you don't need to write these down because that flyer is around, I think. So benefits review and benefits satisfaction. So you want to offer employees in the benefits package high quality evidence-based treatment for addiction, but also for pain. Alternative pain therapy should be part of the package. As a prescriber, 10 years ago, I didn't have a lot of choices other than writing an opioid prescription to treat my patient's pain. I need to have more choices. I need access to physical therapy for my patients, for example. And then opioid prescribing policies. So the benefits package can have those as part of the benefits. Creating a more open culture on addiction. So an employee assistance program that has focused communication efforts that are focused on decreasing stigma and allowing people to come out and talk about their addiction, or their substance use. So it's definitely better to treat this earlier than to wait until the end consequence. In the healthcare setting, you can imagine we have healthcare workers who divert opioids away from patients. Those are sort of the most high-profile, worst-case scenarios. It would be much better if people felt comfortable coming forward earlier before that gets to that point. Communications from top executives. So it does really need to be a top-led effort as far as addressing stigma. Employee surveys. So at BMC, we're now surveying employees specifically about substance use, addiction in themselves and their families in a confidential, anonymous way to find out what our employees need in order to address this issue. Corporate participation and support for community events. The words matter. So that words I just went through, we have a Words Matter pledge where we, during Recovery Month, have people sign the pledge to change their language. Employment opportunities for people in recovery, just so to have examples of people in recovery in your institution provides a big counter effect to stigma, and also allows you to increase your workforce. And outreach to local treatment programs is one way to increase employment opportunities for people in recovery. Generally, don't ignore alcohol use or misuse. And then corporate giving. If you're in a business that has the ability to give, think about this public health problem that is really affecting so many communities. Next slide. If you're an employer that has your employees trained in CPR, note now that since 2015, overdose prevention is an explicit part of CPR training. There's a module you have to take in order to become a community first responder that includes overdose prevention. And that part of that includes naloxone. So that means that if you have employees in your institution that are trained in CPR, they're actually trained in administering naloxone if they take the AHA certification course. So as an employer, I think you should support that training because so make naloxone available in the workplace, for example, and make sure your folks are trained. And next slide. I want to specifically talk about bathrooms because whenever I have talked to employers, one-on-one, this is one of their biggest concerns. And I think we just have to face that the bathroom is a private space that we make available to the public, including employees, employers, and customers, and they are places where people are going to use drugs. To deter drug use in a bathroom is a problem. No one's figured out how to do it safely. All the efforts to try to deter drug use in a bathroom essentially have resulted in worse plumbing problems. You get messier bathrooms. So I'll just give two examples. People tried to put blue lights in the bathroom so you can't actually see your veins and you can't inject. People will still try to inject and they'll hit an artery instead of a vein and then you have a bloody mess, right? If you don't have a place to dispose of syringes, like one of these secure sharps boxes here, then people will flush them down the toilet. eventually, over time, they accumulate, and you have to have a plumber come and fix that problem. So I think what you want to do is try to make your bathrooms safer, and that includes securing them with biohazard boxes. These are healthcare devices. They're not necessarily just for people who use injection drugs. There's a lot of people that inject insulin, and they do it in the bathroom rather than at their desk. They need a safe place to dispose of their needles, okay? So it's not, if you go to any major airport now, and you go into the bathroom, they have secured, this is actually from an airport, okay? So you're not stigmatizing your facility by having a needle syringe box in there. Good lighting and mirrors, doors that open out, especially if you have a small bathroom. When the door opens in, it's a small bathroom, people can overdose behind the door, and you can't actually open the door in. So we've had a number of deaths that have occurred in that circumstance. A call button or intercom system, if that's appropriate. Some of the highest trafficked bathrooms now have reverse motion detectors with timers, which can alert security staff when somebody's been in a bathroom for a long time and isn't moving. And when I'm talking about a long time, overdoses are happening now with fentanyl over 2 to 3 minutes, and an overdose can evolve. So we're not talking about a lot of time. And again, if you're ready for this, you could have safer injection equipment available now that we have really open access to needle syringes in Massachusetts, and then having naloxone rescue kits involved. This is just from the Boston Public Health Commission. 1 in 5 overdose deaths in Boston happen in public bathrooms. Next slide. Okay, so this is going to be a little review. We're going to wrap up here. Some actions to become a model employer. September is Recovery Month, and that's a time I think where it's really nice to focus activities across your organization. What we've done at BMC is featuring stories from our own employees and overdose prevention training. We've also done a CEO-led effort for employees to sign the Words Matter pledge. Sponsoring an employee survey examining benefit satisfaction and corporate climate with follow-up focus groups for additional action. And then during the open enrollment period, I'm talking about opioids, but alcohol is a major player that I think has been with us and will be with us for a long time. And it's something that really hurts productivity. And it's something that now that addiction has been raised as an issue, I think that we should also take the opportunity to focus on alcohol as well. So rethinking drinking fact card mailed to each employee is part of open enrollment. Okay, I don't know if I covered it, but I hope that we maybe have some time for questions, and you can share your thoughts about, and maybe I can give some medical insight into the problem.
So, please, any questions for Dr. Wally? I see a gentleman in the back had his hand up first.
Excuse me. With the upcoming legalization of cannabis, how do you see that in relation to the opioids? One of the things I learned from your illustration there was the fact that both tobacco and alcohol are prime causes of death, and that's what took my dad back when we didn't know anything. But the point is, they are going to be the major distributors. From all I read, that they're buying the small marijuana companies and all that. They're going to be the vendors. Is there any way of protecting people to be aware, as they're doing on TV now and in the newspapers, that these are dangerous things?
Thanks so much for the question. Could you just tell me who your name and where you're from, just so I have a sense of who's in the audience?
Joe Mahoney, and I'm the upcoming executive vice president of the Chelsea Chamber.
Great. So
And I usually say, if you want to get me, all you have to do is dial 877-GETS-JOE.
Okay.
Or www.getsjoe.com.
All right. Well, thanks so much for the question. So, in addiction now, those of us who are, the marijuana question is usually the last question and the hardest one to answer. So thank you for starting with it. So there's a lot I could say about it. But first of all, you can't overdose and die in marijuana. So I'll just acknowledge that on the one hand. There's a lot on the one hand, on the other hand with marijuana. On the other hand, you can become addicted to it. And there is a marijuana use disorder, and that is craving, use despite adverse consequences, and compulsive use, right? Most people who smoke or use marijuana don't have all of that, just like most people who drink alcohol don't. But when you're talking about millions of alcohol users, millions of, now there would be millions of marijuana users, you're going to have a substantial group of people who have an addiction, and their lives are going to be adversely affected by craving, compulsive use despite adverse consequences. So it doesn't kill you immediately, but it is addictive. We don't know the long-term consequences of chronic marijuana use. It probably depends on how you use it and what the concentration is. So there's a lot not known from a medical side as far as research. There have been a couple studies which have actually shown that an ecological association between reduced overdose and increased access to medical marijuana. I think that relationship is very unlikely to play out over time. I think it's what's called the ecological fallacy. So both are true, but they're not necessarily related. However, it does look like that marijuana for pain, we need more research, but can be an effective treatment. And so I think there's a lot more for us to develop there. Now, as far as legalization, you mentioned alcohol and tobacco, right? And with tobacco, when I was growing up, most people initiated tobacco use at 13, 14. And that's still true in some communities, but the smoking rates had dramatically dropped, right? And that's been through higher taxes on tobacco, restriction on advertising, and other reforms, which essentially have been efforts to decommercialize tobacco, right? We have not decommercialized alcohol, and with that, we have seen very little decrease in alcohol use, okay? And it's really because the alcohol lobby has done a more effective job at restricting the government from decommercializing it. So my own view is now that marijuana, I think, inevitably is going to be legalized, we need to do our best to decommercialize it. And you just mentioned how it's corporate entities that are moving into the distribution of marijuana. Well, when you have something that's addictive, by definition, in my view as an addiction expert, if you're a good business person, you're going to direct that to the brains that are most susceptible to using for a lifetime. And that's going to be younger brains, brains under 25 years old. And so you may say, well, marijuana is going to be directed towards we're going to market it towards 30, 35, 40-year-olds. Well, inevitably, the marijuana company that's going to win out is the one that gets the younger users. And if you get people younger, they're more likely to develop an addiction. So that's a complicated answer to your question, but there's a lot of ways to look at it. Is it possible to decommercialize marijuana now that it's legal? Well, we can restrict it in some ways, tax it. We can really restrict the advertising, try and keep it away from being advertised to kids. That's how we've had successes with tobacco. I think we should do the same thing from the get-go with marijuana instead of the experiment that we ran over the last 70 years with tobacco.
Thank you.
In the interest of time, because we're running a little behind schedule, I'd like to take one more question. And I think it's this young lady had her hand up.
Thank you. I advise employers, and we've been starting to advise our clients to have Narcan available. We're getting pushback from some colleagues who say, you should not have Narcan, you're becoming a healthcare provider, you're encouraging people will steal the Narcan, they will use more. What is the answer to those arguments, the pushback that we're getting back about employers should not give out Narcan because you're making the problem worse and you're allowing it to go underground and you're encouraging people to use?
So it's called the moral hazard. One way to call it is moral hazard or risk compensation. So that means that if you make something easier to do, then or less deadly, then more people are going to do it. And naloxone definitely saves people's lives and allows them to live so that they can live longer. It doesn't actually cure their addiction. It doesn't even treat their addiction, right? It just keeps people alive longer so that they have the chance to get treatment, or they have the chance to find recovery. So naloxone itself has a limited but very important impact. Does it encourage drug use? Well, I could just tell you, you'll have better experts that are in the panel. The last thing somebody with an opioid use disorder wants, the last thing they want is to die. The second to last thing they want is naloxone. So if they have to choose between naloxone and death, they'll pick naloxone, okay? But they really don't want naloxone. Whatever that person had to do to raise that money to get that opioid that day, once you give them naloxone, they have to do that all over again. And they don't want it, they already did all that work, right? Whatever it was. In some cases, it's pretty distasteful things that people have to do. So it's really like the last thing that people want to do. This fascination with this moral hazard, risk compensation, we've seen in public health problem after public health problem, okay? There were people who felt that if we required people to wear seatbelts, we would actually have more traffic accidents because people would drive more riskfully, right? That hasn't happened. In fact, we've seen a dramatic improvement in road safety from people wearing seatbelts. How many people have a fire extinguisher in their kitchen? Are you trying to? Are you doing it because you want to be able to light your kitchen on fire? No. And who didn't raise their hand? It's like a code. You're supposed to have a fire extinguisher in your kitchen. So that's my answer to the risk compensation moral hazard issue.
Thank you.
Yeah.
So we should move along. I told you that we were lucky to have Alex Wally, Dr. Wally, with us. So please give him a round of applause. All right, I'd like to ask our first panel, all four speakers, to come up, please. That would be Steve and Kathy and Allie and Will. Yeah, please.
Jeff, since I'm already dealing when speaking, but if there's a question, I can answer from there.
Okay, so this is what our employer's doing. And we have three speakers. I'll introduce them all now. Stephen Powers is a business owner in Chelsea, owns S&L Cold Cuts. He's also a founder of Sober Homes. And he has a personal story to share with us about employing people in recovery. We have attorney Ariel Kristen and her colleague Kathy Rubin is also in the audience, and they're from the firm of Hirsch Roberts Weinstein, LLP. And then we have Will Brown, who is from All One Health, an organization that provides employee assistance programs. And he's director of EAP operations for the New England region. So first of all, I'd like to call on Stephen Powers to talk about his experience in employing people in recovery. And I will give you this microphone.
Good morning.
Yes.
It's not very often I follow someone like Dr. Wally, normally talking about much different things. My story is, it's the only thing I know about addiction is what I watched for over 13 years with my younger brother. First, let me start by saying I have a construction company on top of the two small restaurants, and then the sober house kind of filtered its way in. There were 5 of us, and my brother is in the middle. And sometime around 1999 or 2001, he began to get ill, something that we didn't know. No one knew what it was. And instead of just going out and drinking and having a good time and coming back, he would be out longer and more and further and faster, and it never ended. Sometime around 2008 or 7, it got to the point where he was overdosing regularly. Everyone in my family has found him blue at one time or another. The Revere Fire Department at one point revived him in front of Phenos, and there was really nothing. My mother was calling it an epidemic in the early 2000s when no one really wanted to call it that. And until people started really dying in expensive neighborhoods and movie stars, then it became something that everybody had to pay attention to. Well, around, I'd say 2008, I had just flung him out my front door like normal because he was going to do better, and he went away and we couldn't understand. And all of the things that Dr. Wally said, they're right on target. It's exactly how it works. And he'd be doing better, and you couldn't understand why he would go back to such a lifestyle, but sure enough, he did. And again, I tossed him out of my home, and it was an ugly scene, and I have small children, and I made a promise. I said, make my brother well, to whomever it is you asked that to. I asked it to every single one just to hedge my bet. I would do something. And I don't know what that something was. I didn't know anything about this. About 8 months later, he went away and he came back, and he looked good. He was 29 years old. He had no sellable trade. And I realized I had made a promise. So I purchased a 5-room home in Lynn, the worst home Lynn had. And, there were a lot of them, so this one was really, really bad. And we worked on it nights and weekends together. And we opened it up when he was about 13 months old. And he looked at me and said, "Can I run it?" Up until this point, you couldn't trust him to mail an envelope. If you handed him an envelope and said, "Mail this," you had no trust that it was going to make it to the mailbox. There was no way that that person that I had watched all those years was who he wasn't meant to be that person. I said, sure. He took that thing and he has run that like you can't believe. We're the first certified men's sober home in Massachusetts history. We have 7 locations, over 100 beds. We've just opened up a woman's house. My brother is a successful businessman outside of that. He has 2 beautiful children, a great wife, and his life it's wonderful. Now, in the interim of all of that, I didn't realize I was doing it. Someone here pointed it out to me and said that I should come here to speak, is that I had been employing people because what I would call my brother's drug representative is much different than my brother. My brother's drug representative is unreliable. He will do bad things. He will not be accountable. But my brother, whole different story. Guy does amazing things, helps people, and it really has made a difference. So there are 2 separate people there, and I recognize this. So I started hiring folks. And at the construction company, it came first, where there were a lot of tradesmen. This thing has impacted tradesmen like you can't believe. And I started hiring tradesmen. And you go into it with all the cards on the table, which is nice, because I don't know what the percentages of people that get hired for sandwich shops and plumbing companies and construction companies are, but it's high. So if you go into it with your cards on the table, everybody knows what to expect from it. So you don't have to play that game when you notice them in the corner and their chin is to their chest and their eyes are all loopy. Geez, what's wrong with Bob? And you know what's wrong with Bob, and you can attack the problem. Bob, here's your choice. You could either go get some help or get your bed somewhere, or you have to move on because I don't contribute to it. In doing so, the construction company, the plumbing company, is about 50% employed by guys in active recovery. We're also the only company that everybody talks about as having no one on drugs in it. And because there's no sign, because I've sat in meetings with my brother, sitting there, and somebody's so obnoxious that, oh, I could spot one of them a mile away. Well, my brother's one of them. You couldn't spot him, you didn't know who he was. One of the sandwich shop is employed by 90% of people in active addiction. And the third one is probably a little less, closer to 40%. There are some hiccups. You do have to put up with some stuff, but no more than you'd have to put up with if you had a really bad employee. Now, the upside to this thing is you may discover a diamond in the rough, because they're there. They're all out there. They're the people that you pass by in downtown Boston in that hospital district down by the meatpacking plant, where they're looking less than human at this point. They're sleeping outside. They're with the duffel bags and the Nike Air Max on it, but they're in there. That's somebody's son and somebody's brother and somebody's daughter that had great plans at one time, that had probably gained an education prior to falling off. And if you can discover that person and bring them into your organization, you'll benefit from it tremendously. I have. We don't at the sober home, and I don't at my business, offer, addiction used to be one strike, you're out, I learned. Oh, you go into a program, you use, out the door you go. I couldn't get my head around that. I make 50 mistakes a day, that's on a good day. I cannot believe that at the end of my day, if I made a mistake, somebody come up to me and say, oh, hand all of it back, you've done screwed up. It can't be that. So you have to offer a plan. Now you can't live with somebody or work with somebody in active addiction. It's too treacherous, the rules of the game change dramatically. But you can offer them a path to recovery. And now that the system has changed so much, there is so much out there that there are beds and programs and people to speak to that you can go back to getting help the next day. And that's part of what I've seen. Again, now I don't have any professional experience. What I've seen is one of the biggest problems was somebody would get 12, 13, 15 months of sobriety, begin to build all this goodwill up, have one bad evening out there, fall off with a Neurontin or a Wellbutrin or something not even as serious as an opioid. And that's it, it's all over. That's it. Their mentality was, well, I might as well burn this thing to the ground. I'm gonna just go as far as I can now because it's all lost. But it's not. Let's start again tomorrow. Let's get, you have to have someone like these folks diagnose how far you are, where you are, and see if you need treatment, you need an outpatient program, you need to go stay at a detox for a little while. But the upside to it is unbelievable. And I promise, if you hit it right, and you stick by someone, and you take someone when no one else will, the Christmas cards you get are way better than the ones you get now. So that's my story. We've purchased another location. Cities are no longer saying we don't want that in our town. We did all this with zero money from anyone. We did it from ourselves, from my mother and father, who at the end of that, we were in like 2008, 2009. The market had collapsed, so there wasn't a lot of funding around. But every step of the way, every time we put this on a personal level and not thought of it as a business, it grew exponentially. It just kept growing. And we've, I think now with seven locations, and purchased a building last week. So with everybody helping, that little percent that the secretary talked about ticking down, that's hope. That's hope. There's a funeral a week for the circle of friends I have. And so you've got to believe that if meetings like this and people somebody has to be, I always say this, my group of friends, is that if you took a guy off the street in like his worst place, and you know how that looks, it sometimes looks very, very bad, and you bring him to a fidelity meeting and sit him up front and say, hey, anybody here want to help him? We're looking for some cell phone numbers. Probably not a lot of people will raise their hand. You bring him to an NA meeting, sit him up front, say, hey, this is a good guy and we want to help him. Everybody in the room will raise their hand. We need to adopt more of that. that they're real people and they just need a hand. And once you get past this, then the things they can do are unbelievable. So that's my story, and I guess I answer questions. Anybody? Afterwards?
We'll do Q&A after the.
Good morning, my name is Ari Kristen. I'm a labor and employment attorney and a litigator at a firm called Church Roberts Weinstein in Boston. And before I start, I want to thank Stephen for telling his story and for the very important reminder that what we're talking about here are people. And we're talking about people who are affected by this epidemic in various ways. And so what I'm going to talk about a little bit this morning is what the law says, excuse me, what the law says about how we treat people who are affected by this epidemic. And before I get into that, I do want to introduce my colleague Kathy Rubin, who's here at this table. We figured in the interest of time, I would go it alone on the panel, but Kathy and I will be hanging around after this morning's event to answer questions, to talk with folks, and we'll get our information. So because of the limited time this morning, we're going to be hitting, or I'm just going to be hitting just the highlights of what we think are the most important employment law considerations in the opioid epidemic. But we are also giving you this green packet that's in front of you, which is called the Employer Resource Toolkit. It's something that we worked with the Mystic Valley Public Health Coalition on, and this has some incredible resources to help employers navigate the waters around the laws that I'm going to be briefly discussing. And I'll be highlighting some pieces of it. But hopefully between what we do this morning and this toolkit, you'll have a basis to really think about and work through these issues. And as we go through this, I want you to think broadly about who in your workforce might be affected by this epidemic. And the speakers before me have really hit it. It is not just your employees who might have a substance use disorder. It's also an employee whose child has a substance use disorder and who's taking care of her grandchildren. It's somebody whose friend might have a substance use disorder and might be dealing with the repercussions of that. These folks might be missing work. They might not be as productive when they're there. And so let's think broadly about that as we go through this. We think about three main ways in which the opioid epidemic impacts employers. The first one is safety. Basically, you do not want an employee who is actively using substances in a safety-sensitive position doing something that might hurt others. So think of somebody who is using opioids operating a forklift or driving a company vehicle or doing any of the other innumerable things, operating a cold cutter, working with a stove, working in a kitchen, things like that. So that's the first one, that's safety. The second is productivity. Dr. Wally addressed this a little bit, but the idea is that this epidemic has had an incredible impact on the productivity of employees and their ability to contribute in the workplace. So again, think of an employee who's taking care of her grandkids because she's got a son or a daughter who has a substance use disorder. And then finally, liability. So there are two parts of liability. The first, going back to safety, is the liability of the employer to somebody who might be hurt by an employee who's using opioids. Again, think of an employee driving a company vehicle while using an opioid, gets in an accident, and what that's going to mean for your business. But on the other hand, let's think about employees, our liability to employees who are affected by the crisis and whose rights are affected by the law. And this is actually where we're going to focus now. So next slide, please. So what do employers need to know about the key laws that govern how employers interact with people who might be affected by this epidemic? So there's three. We'll start on that far left with the Americans with Disabilities Act, Chapter 151B. Chapter 151B, for folks who don't know, is a state law here in Massachusetts. It does a lot of things, but what we need to know for this is that it acts like the Americans with Disabilities Act, when we're talking about disabled individuals. And in general, with the small exception of how it treats medical marijuana, these laws are almost exactly the same. So I'm just going to refer to the ADA, the Americans with Disabilities Act, but I'll be referring to both of those. So the ADA has a positive commandment and it has a negative commandment. The positive commandment is, thou shalt provide reasonable accommodations for qualified disabled individuals. That's on one side. On the other side, the negative commandment is, thou shalt not discriminate against qualified disabled individuals. And for a lot of employers in the room, I imagine that you've interacted with one of these two commandments of the ADA. It's something that where we do a lot of work, especially on the reasonable accommodation side. The important takeaway for this morning, when we're talking about the opioid epidemic, is that substance use disorder is a recognized and protected disability. Now, it's kind of interesting and kind of complicated because substance use disorder is a recognized disability, while the current illegal use of drugs is not. That can be a difficult line to parse, but the bottom line is, if you have an employee who has a substance use disorder, who has gone through treatment, who is going through treatment, that person is protected by the Americans with Disabilities Act. That means that if they need a reasonable accommodation for something like going to treatment, going to a meeting, they need to change their hours a little bit, you need to engage in what's called an interactive dialogue and work with that employee on whether whether you can and need to provide those reasonable accommodations. In the toolkit, on page 23, I'll point you to that, we have an EEOC guidance on the Americans with Disabilities Act, and we also have a reasonable accommodation policy on page 39. So there are some resources there. So that's the Americans with Disabilities Act. Moving to the middle, to the Family and Medical Leave Act. The Family and Medical Leave Act says that for employees with over 50 employees, you need to provide up to 12 weeks of protected leave for employees who are dealing with serious health conditions. And that's their own serious health condition, and it can be the serious health condition of certain family members. And again, what's important here, when we're talking about the opioid epidemic, is that a serious health condition can, in certain instances, include substance use disorder. So if you're a larger employee, if you have 50 or more if you're a larger employer, if you have 50 or more employees, your employees may be entitled to take time out under the FMLA to get treatment for themselves, to help a family member get treatment, to engage in other activities that they need to if they have a substance use disorder. And finally, all the way over on the right, we have the Massachusetts sick leave law. Actually, before I move on, in connection with the FMLA, if you look at page 57, there's a notice of rights under the FMLA. And if you have 50 or more employers, that's something that you should be making available to your employees. So finally, all the way over on the right, we have the Massachusetts sick leave law. And if you look at page 41, we have a sample policy for the Massachusetts sick leave law. This is something that it's an area where we do a lot of work because this is sometimes a difficult law to parse. But essentially says that employees can accrue and use up to 40 hours of sick leave. And they accrue this at the rate of 1 hour for every 30 hours worked. And for most employers, that has to be paid leave. For some employers, it's unpaid. But again, what's important here is that one of the ways that you might see that sick leave used is for something having to do with a substance use disorder. So it's important to know the ways in which employees are protected by these laws and your obligations as an employer under these laws. I want to touch briefly on drug testing in Massachusetts. And again, this is can be a complicated area. And everything we talk about this morning, you need to consider your own situation as an employer and how these laws apply to you. This is particularly true when we're talking about drug testing. And really when we talk about whether a drug testing policy is lawful in Massachusetts, we're balancing two things. Privacy laws and the privacy interests of employees and the legitimate business interest of the employer. And the courts have looked at this over time, and they've said that certain types of testing are generally permissible. So pre-offer testing, so before you give somebody an offer of employment. Post-accident testing, when that accident could have been related to drug use. Testing when there's reasonable suspicion of drug use. And random testing if it's required by law or when you're dealing with a safety-sensitive position. A couple words on drug testing and drug testing policies. I noticed one of the speakers before, or actually I think it's on that sheet that we received from the Massachusetts Health Coalition, suggested having drug testing policies. And I think it's important for employees to know what the parameters are for drug testing policies. And it's also important to protect you as an employer to put out there how you're going to handle drug testing. So you want to think about what do you want to achieve with the policy? Do you want to have reasonable suspicion testing? Do you want to have random testing? Is random testing something that you can justify based on your legitimate business interests? Do you have safety-sensitive positions? And then consider working with an attorney for help with drafting the policy. Again, it's a complicated and nuanced area of the law, and you want to take into account what your business needs are, and then also how that works with the parameters of the law. And having that clear, lawful policy up front really saves headaches in the end, both for employers and it helps employees know what to expect. So I've talked a little bit about what the law is, and those are your obligations as an employer. They're essentially the floor. They're what you must do, what you can't do. They're these sort of big commandments that come down from the government and say, this is what you have to do. This is how you have to treat people. But we also like to talk about what employers can do beyond what they're obligated to do. And some of the other speakers have spoken and will speak about this, I think. In our experience, there are policies and practices that can create a supportive environment for individuals who are affected by opioids and encourage them to be open with you about what they need. So the first one is to foster a company culture that encourages employees to come forward. Again, that openness, addressing the stigma. I love the idea of the pledge to use positive language and people-first language. Second one is to offer resources and benefits to support employees. I know the next speaker is going to be talking about EAP programs. Implementing clear, lawful policies on time off, leaves of absence, reasonable accommodation, and substance use. Like we were just talking about, having those policies, one, lets employees know what to expect, and two, can save you a lot of time and trouble down the road. And then the fourth one is seek guidance when dealing with substance abuse issues. Sometimes that can be legal guidance. It's about talking to an attorney about what reasonable accommodations are required under the law. Sometimes it's an EAP. Sometimes it might be calling the local police and saying, hey, we've got this issue, we need some guidance on it. There are tons of resources out there. There are lots of folks talking today who can offer great resources. And we encourage you to reach out and to fight that stigma when you reach out. Thank you very much, and we'll be around afterward to answer questions.
Stretch out here and so what Secretary Sutters said is just so true. Thank you for caring. I'm the clinical social worker, and as I say to people, it's all about caring. If we don't care, why are we here? So you all are here because of that, and so I appreciate that. So as a segue to what Ari just said is, EAPs and the employer and the costs. And EAPs got started in the 1940s in the automobile industry because workers on the assembly line were experiencing addiction. And so the employers banded together and formed programs. At that time, they weren't called EAPs, and thus was the birth of EAP programs. At the time, self-help was on the ground, just started as well. And so you see this taking hold in our society. What's interesting about this topic, as I've given presentations about this, is that it's, addiction has always been with our country, from the start of our country. And it's just morphed into different forms of different kinds of addictions. I mean, the last question was about marijuana, and so we're looking at how to understand that and study it more. So EAPs are an important player, as this really takes a village to address in terms of what we're talking about relative to addiction, which is the biological, the psychological, and the sociological considerations of how to address this. We have to really understand fully what the implications are as it relates to the workplace. And EAPs have just been around and have had that inroad into supporting the employer, because at the end of the day, it's really about productivity and health and wellness as far as what you're attempting to do to support employees. So this is a tool for you all and to make a difference in the lives of your employees. And just having that available is what we're doing. It's a 24/7 resource. It's the facts of the AP. The F would be that it's free. There's no cost to use this resource. The A is that it's available 24/7. It's also available to anybody in the household. So roommate, a loved one that lives with it. We also offer it to dependents. So the C is that it's entirely confidential. The exceptions to that would be if there's anybody at risk to harming self or others, or there's any kind of child neglect or abuse neglect, and another exception would be a court order. We're really all about prevention. And some of these details here, just kind of as a backdrop about what we're doing, which is customizing programs. Part of why I think we're here is not only to be a partner toward the efforts toward addressing this problem, but to look at what associations can do. Chamber of Commerce's, we've had this type of group purchasing. You're taking advantage of a pool of people that you can cover as far as an EAP goes. So we can customize an approach. I was working with a farmers association in Burlington, Vermont, around putting together an on-the-ground support program for farmers who are dealing with mental health issues, suicides, as the financial constraints around this industry are squeezing some of these dairy farmers. So, as social workers, we're really looking to bridge a lot here and put together a support. The other thing to think about is that people can call about acute mental health issues if somebody is suicidal. I just had a call last night about somebody, and we are following through and making sure people are safe and they have the proper assessment and treatment programming going on. Often our EAPs are providing a number of sessions at no cost. So, whether the per capita, this is kind of the pricing model of how it works, is that it's per employee per month for the benefit of 3 visits per employee. They can use it multiple times. It's per situation. So that's kind of the core of this. But we're doing much more than acute issues. It could be legal consultation, financial consultation. It can be broad-based. The best example that I have over the 20 years that I've been practicing at All One Health EAP is that a woman was calling about her husband. Her husband, she's a teacher, and her husband suffers from, at the time they called it multiple personality disorder, and now it's called dissociative disorder. So he would go into another ego state, and this ego state was a female persona. And so she was terrified because this was day 3 and he wasn't returning to his primary ego state. He was still in this altered state. And so I recognized really clearly as she's calling, and it's an assessment by phone, she's calling, she doesn't know what to do, she's really in a crisis. I said, well, how about if we talk with him, if he can come onto the phone? And at first she was really reserved, she didn't want to do it. But she did agree, and he came onto the phone, and we worked for probably an hour that first conversation. and engaged him enough to agree to have a follow-up the next day. And so the conversation that we had was all about, because we talked about getting evaluated, and I found a specialist that, I mean, this is very specialized for somebody to work with somebody with a dissociative disorder. So it took a while to find somebody. And then what we talked about was what he would wear leaving the house that wouldn't defy his identity, that wouldn't breach his sense of, you know, being noticed when he left the home. So we talked about gender neutral clothing, and what he would wear was a white t-shirt, jeans. That's the level of detail that goes on in terms of what you have as a resource, because you just don't know what's lurking in people's lives. And so that's our game, is to provide that compassionate care and support people no matter what it is. If they just need a resource for child care or elder care, this is what we've got our fingers on. I know we're kind of, the time is short, so I'm just going to say two other things as it relates to our topic in terms of how are we contributing as far as, you want to advance this line here because this will give you a sense of what we do. This is what is a core feature of EAP. Just back up one more. It's called a formal referral. So you're using your influence to assist an employee to make the call and get some help. So employee has an ongoing job performance problem, and you suspect that personal problems. Now you may notice that it's substance use related, or you may not, but something's getting in the way, and you call us. And this is what I wanted to say with Ari. It's consultation with us as to what would be an appropriate solution. So it's talking to us about these complicated issues related to addiction, the kind of enabling that can go on, etc. So you're also not alone. If you have an HR person, maybe you're the only one, but don't be alone with these kinds of issues. You know, potentially it's there's legal implications here, but you're trying to get this person some help. You're intervening with them, talking with them, and saying, hey, I've got an EAP resource. These are good people. I'd like you to call them. I already gave them a heads up that you'll be calling, and you give us a backdrop of what is the context of this person hopefully calling us. And then so that employee calls, we evaluate them, and we come up with a treatment plan and hold them accountable to that in terms of reporting back to the employer about their compliance to that treatment plan. Now, you don't have to go into that compliance mode. You can just direct them to the EAP. So there's just some choices that you have around that. That's a core, this is a really big part of EAPs. It's a part of our core technology for this industry. And so the last thing that I wanted to mention is we have a hospital that we provide EAP services to, and one of the managers called and said, you know, we have a situation where a nurse was diverting fentanyl. You know, this is the most potent. It's killing majority of people that are dying of opioid, the opioids. So she said, you know, so this guy took the drugs, and we had to terminate him. And it's really created quite a stir amongst the rank and file, the doctors, the nurses. It's a smaller hospital, but nonetheless, and they don't have like a diversion. They don't have a program on sort of regular education about how to address these kinds of issues. So there was a lot of just not being aware of what does the hospital do when these things go down? Do they report it? And so in the room, it was a packed room, and it was all about providing information, but really facilitation that, you know, do people know what the policy is? And the president of the hospital spoke about what the policy is, what they are required to do, and then helping people talk about the issues. You know, some of them knew the person, some of them are enabling, potentially, the coworker looking the other way. What are the signs and symptoms to look for? And is it okay to report this? You know, breaking down some of that culture about just people not talking as it relates to this problem. So it's an example. It was in a 1-hour program, but it's heightening a sense of awareness and putting the emphasis on the employees, the employers, about what can they do. It's kind of like this in a sense, is what are some ideas that could come from this that you could make a difference in your workforce. So I'm going to just sort of allow the Q&A to take course here at this point.
Because we have excellent speakers this morning, I think everything I've heard is very valuable, but we're running, maybe 10, 15 minutes over. The hotel will let us stay later, so anybody that can stay a little later, we can do that. But I'd like to just take a couple of questions now, and all three of these speakers will make themselves available to anybody that wants to speak with them about what they've said later. We can connect you with them, just to let you know that. So would anybody like to ask a question of either Steve or Ari? Yes.
Eve. Thank you. Eve Sullivan, Parents Forum. We're running workshops in Chelsea, Revere, Family Network, and Winthrop. My question to you is, where does parenting education come in? Because I haven't heard that word. And as the mother of young people who are no longer young and no longer using, I know that the support I got as a parent made a tremendous difference. And I have to say, I admire each of you for your work, and thank you.
Parenting education.
Well, years ago, when I first started the industry, when I first started in the business, there was much more of an effort to reach parents and to educate them about parenting issues. In this industry, it just hasn't really been in place, to tell you the truth. So there's a lot that we can do. We're often working with HR liaisons and talking about the particular programs or trainings that we can offer. And we do offer that, but often it's not elected. But there's a lot to be done to really create more dynamic programming about this, just basic education. And we're seeing that. We just did a program about basic opioid awareness. And there were a lot of people that attended that, because if they did attend it, they'd have 1 month free off their health insurance, their copay. So, you got to bring them to the water and get them there. It's just, we're all sort of in this, electronic age where training, you can start to see the numbers for training go down, unfortunately. So webinars are also what we do too, and that's going to be effective. I don't know if anybody else had anything to say. I mean, parenting is everything, right?
And just that, as Ari had noted, that under both the Family and Medical Leave Act and the Massachusetts Sick Leave Law, and under the Americans with Disabilities Act, people who are associated with persons with a disability have certain legal protections as well.
Thank you.
And that's the parents.
So can we have another question? Yes.
Cheryl Queen, I don't do that. Cheryl Queen, Twist and Shake in Revere and Winthrop. Stephen, I have to tell you, your story is very, very, it's amazing. Do you currently drug test with the type of employees that you have?
I don't. Case by case basis, and again, during an interview, bringing someone on, I let them know that I bring it in as something that I do. I say a lot of people in here are in recovery, and that helps them to, if they're having a bad day and the person next to them is also in recovery and can maybe help them along with some feelings or some things that they're going through. So then it becomes like a word of mouth thing, and that I hire people that are in recovery. So the cards are kind of on the table, so there's really no need. It's usually a conversation. Mm-hmm. You and I work together every single day. I know what to expect from you each morning that I show up or that you show up. And if you're not behaving in that normal way in which you do, right away I ask, are you all right? What's going on? Have you had a bad night? Is something wrong with you? And normally, not in fear of losing their job, or not in fear of being labeled, or being, called out, it'll just come right out.
Right.
I screwed up. Soon as we can remove them screwing up with being the end of the world, it'll just be a little easier to do, and then you can get right into what we need to do, which is get them to the people that deal with this stuff on a medical level. So I don't, but the Sober House does. The Sober House is test professionally. They have a company come in twice a week at every location. But that's kind of like a different.
Can I speak into the same question?
Sure.
How you said you were the first house to be inspected?
Certified.
Certified, and what does that entail?
Let's question about Sober House, and then we have one more question after that.
I don't know.
How many times?
I have no idea.
I was just wondering, how are they regulated? They checked every certain month?
I know that to become certified, there was a big process. The secretary had a staff of people that found us and said that, that kind of all roads were leading back to my brothers and I regarding sober housing. When we took this on, you have to understand each bed represents a dollar amount, and that dollar amount's pretty high. So most people are paying, family members and stuff are paying to keep their loved ones away from their home because of the drama that they're causing. It wasn't to make them better, because sober houses back then weren't making anybody better, they were collecting their money. So what we've done is we've changed all that, and the money is secondary. Although it is exactly what runs the house. It pays the mortgage, pays the bills, the staff or the management. But every house we have is as nice or nicer than the house you grew up in. And that's on purpose. Each room we have is normally single occupancy unless the building code, like we have a really large room that we can't split because of certain code violations, but no more than 2. Because how are you going to give somebody back their dignity sticking them in a room with 5 people, or trying to get their lives back online? So we run the house as best we can, and I guess the government or the state recognized that, and from this point forward, the game has changed.
Can I get a quick point on that? Just a very quick point on the drug testing. Think about what you're testing for and how the tests work. And you can often talk with drug testing organizations, companies that do this. For example, marijuana shows up for a very long time on the drug test. And do you care if your employees are using marijuana recreationally over the weekend? How long would an opioid stay on the drug test? If what you're really worried about are people using opioids at work, people using substances at work, think about how you do the drug testing, how you set up your substance abuse policies to address that and not necessarily other use.
Thank you again. All these folks will be available offline if you want to continue to ask them questions. Bob.
Steve, one quick question. Do you hire people from Revere, and do you have other people like you? Because I work for Cambridge Health Alliance, helping people coming out of jail, and 80% of them have substance use problems. One of them almost died the first weekend he was home at Mass General's overdose. The other fella, we work with his family, he did die of an overdose. This fella that came out and survived needed a job. I didn't know about you. There's no organized way to know about people like you. I know one other employer in Everett, where I also work, who intentionally hires people coming out and with substance use problems. And most of the people he hires are such people doing a great job, it looks like. So yeah, will you hire somebody from Revere, because I want to talk to somebody about you. And do you know other people who are doing what you're doing as employers?
I don't right now, and I'm kind of a weird breed, because I have a pool of people to choose from my sober houses, and that's normally how they've kind of integrated into the company. But the thing that I see, and I didn't say anything earlier about it, it slipped my mind, I was a little nervous, but so the removing the drugs and the getting people better, or to live a different routine or a lifestyle, that's pretty hard, but okay, it can be done. The problem is when the insurance runs out and these programs stop, and then they open the door and say, okay, go head out into the world. With what? With what trade? With what ability to make money? And if you wandered around all day long, not having a job, not feeling secure about yourself or being able to provide a living for yourself, you'd probably resort back to it too. So what we need is more people, more training, more technical training, I think, in some cases, to give people a chance at living a normal life. And there will be bumps. There will be times when the guy relapses and you have to say that's okay. I know that it's going to kind of jam my day up for 2 or 3 days and the scheduling's going to get a little screwed up, but it's a human being. It doesn't just get discarded because my bottom line isn't going to, is going to suffer. And if some more people take that on, then I have a personal reason for it. So I don't also look down upon anybody that isn't doing it that way. But we need to open up more of the easier jobs that somebody can work their way out of. So like if you could be a laborer in a plumbing company, carrying pipes and tools, but go to school at night and then become a licensed plumber in a few years and then be able to really support yourself, that's the goal. And yes, you can send me anybody you'd like.
The North Suffolk Public Health Collaborative is going to have a presentation by the Building Pathways Pre-Apprenticeship Program into the building trades later this year, just to let you know. Please give a very strong round of applause for the speakers. Again, you can connect with them after the conference. Okay, I'd like to invite our second panel up now.
As they come up, let me just respond to this woman's question about parenting. You know, EAPs do work with parents. Ma'am, EAPs do work with parents clinically. I was thinking of training, just to add that in here. So that when we get a call about a child that's involved with drugs, we'll definitely work with them clinically to address it. As far as training and education, that was what my point was. I just wanted to add the clinical piece.
Okay, we have representatives, well, let me introduce them. We have, try to be quick about this. We have Julia Newhall and Carrie Ann Salemi from the Substance Use Disorders Initiative of Revere. We have Lieutenant Amy O'Hara from the Revere Police Department. We have Sergeant Sarko Jagarian from the Winthrop Police Department. Chris Alba from the Healthy Streets Outreach Program, works in all of our communities, I think. We have Captain Dave Batchelor from Chelsea Police Department, and Dan Cortez, also from the Chelsea Police Department. So thank you very much. I just want to make the point that there are multiple coalitions of different kinds in our communities. Some focus more on prevention of substance use disorder issues. Some focus on treatment and recovery and outreach. This panel is more focused on treatment, recovery, and outreach. The other coalitions will be engaging with the business community and employers more throughout this year, but that's who we have on the panel today. So thank you very much for being with us. So I think, I don't know what order we want to go in, but my suggestion was that you each talk to us a couple of minutes about what you're doing, and particularly how you engage with the employer community and partnerships within your communities to keep the community safer and help people who are dealing with addiction. So I might start just left to right, if that's okay, with Julie Newhall, who's with the SUDI program in Revere.
Am I good? Okay. Hi, everybody. My name is Julia Newhall, and I'm the director of the Substance Use Disorder Initiative Office, which is a municipal department in the city of Revere. We're located at 437 Revere Street, and we launched in 2016 in October to really streamline and align existing sub-related programs. As Jeff just mentioned, there are a lot of existing activities and initiatives, and we saw that we were seeing silos, and we wanted to create some unity to that. So as we launched, we inherited existing programs that that were developed prior to our opening, and one of those included the overdose outreach program, which started in 2015 and was proposed to go out post-overdose to residences that fire department or police department responded to where an overdose took place. And with a team of community health workers, police, and fire, each week, Tuesday evenings, they go out and they respond to these residences. Their main goal is really to just engage and provide access to Narcan, but beyond that, it's to follow up and make sure that they're getting the services that they need. And we were lucky in Revere to hire Carrie Ann Salemi, who's sitting next to me. She's our part-time direct services coordinator, and Carrie Ann's role is to provide access to that care. And we're available every Tuesday evening as well for a drop-in center that we host every week from 5 to 8. We provide all types of services such as peer support, treatment navigation, overdose education, naloxone for people who are actively using or for bystanders. But one of the things we noticed with our outreach program was that many times it would be in a public place, and that included local businesses, bathrooms. We started to track that information separately, and now are trying to respond to those businesses and offer naloxone training so that if somebody does in fact overdose at your place of employment, that you or your employees know how to recognize an overdose and how to respond to it. And then we also have the follow-up piece through a resource that's already within the city through our office. So that's pretty much what we're doing as far as engaging local businesses. I do want to add to some of the comments about getting people back into the workforce. And one of the things that we see regularly, and I know personally, is the ability to, once you get there, is to get your life back together again is gainful employment. And a lot of people who have been impacted by this issue often have a quarry, and it's very challenging to acclimate back into society when you're not given a chance to do so. People are just like you and me who are in recovery, and they truly are great and empathetic and smart, wonderful people. And I can't say enough how grateful I am to have these types of people in my life and within our office. So, that's certainly one of the things that I think we need a lot of help and a lot of more effort into thinking about how do we help people, not just revive them from an overdose, but help them acclimate back into their community and be an active participant in how we develop programs and things like that. So we're here if you have any questions or.
Hi, Carrie Ann Salemi. I'm with Julia, so basically everything she said was what I was going to say. But the one thing I did want to add is that we are trying to start to engage businesses. Like Julia said, where overdoses have taken place, whether it be in the bathroom, in the parking lot, we get the data on that. So we're trying to, I have made attempts to a couple of local businesses to try to speak with some managers and get some feedback and see, their thoughts on, can I provide you with some Narcan to have in the business? Can you, asking them about bathroom safety, that type of stuff. And, I got a little pushback with a lot of the managers. Most of them told me, oh, we have to talk to corporate, we have to email them, we'll get back to you. No one's gotten back to me. But there was some pushback. I think people are fearful, like, I don't want to have to do that. I don't want to have to try to give somebody, Narcan or CPR or whatever it might be. But it's just around educating people on, the signs and symptoms of an overdose, checking the bathroom if somebody's in there too long. Do you have a buzzer? Do you have a key to get in? What is the protocol around that? Because this is where most of our overdoses are taking place, unfortunately, is in a Dunkin' Donuts bathroom, in a McDonald's parking lot. So we really need to just try to educate people and find a little bit of openness to hear what we're saying, because I know the fear is, I don't want nothing to do with that, I'll call 911 and that'll be the end of it. But it really can make a difference, you can really save someone's life and they can have a chance at recovery, because I was one of those people. And in a couple of weeks, I'll have 17 years in recovery. And I'm employable, I'm reliable, I'm a hard worker. The most genuine people I have ever met in my life are people in recovery that suffered from substance use disorder. The best people I know. And when somebody is actively using, I think Stephen was talking about it a little bit, if we just engage them and tell them like they're not in fear of losing their job because they might have a problem, it makes a world of difference because they want to be honest. They lie because of the consequences they have to face. So if you say to them, are you having a problem? How can I help? How can we, work together? They'll be open. People will be open. They'll tell you, I need help. I'm struggling. But if they're in fear, like, hey, I need a drug test right now, and they're going to lose their job, they're not going to be honest. And they're going to lie. And, the stigma is really what's holding people back from being employable, from being in recovery, to finding new ways. Like, just show a little compassion, a little understanding, and it goes a long way. So, thank you.
Good morning. My name is Amy O'Hara, and I'm a lieutenant at the Revere Police Department. I'm the commander of the Division of Community Services. This is a newly formed division that we just started in October. It's equally as important as the patrol division, the traffic division, and the criminal investigation division. It really serves as a dual purpose. One is we organize programs that promote unity and spirit of cooperation throughout many segments of communities. So that would be the police academy, the junior police academy, and so forth. The other side of it, it's our mission to enhance the relationships, enhance and improve on the relationships between the police department, our citizens, and stakeholders in the community. So we collaborate on ongoing issues that the community might have. I've worked with my colleagues here on several issues, and obviously the opioid epidemic, the Revere Police Department has a part in the solution. Now, I've had a relationship with my colleagues here for the last 5 years, but the newly formed division, it's more of a full-time position where they have more access to me on a 24-hour basis, so there's quicker response from the police department in any issues that may come up. Now, the police department has 8 officers currently assigned to the SUDI office that will go out with them on a weekly basis to offer resources to those in need. And what determines who we go to comes from information through an analyst at our PD that obtains information from the fire department and the police department from our calls of service. And with that information, we bring it to the outreach workers in the police department and the fire department. We'll go out on a weekly basis to offer resources. I also serve as the Narcan coordinator for the police department, which means currently our line officers out in the street since 2015 have been carrying Narcan. So if they do administer it, I replace it and make sure it's reported through DPH. I just wanted to let you know that almost 5 years ago, it was from my colleagues here that were able to educate and inform me on substance use disorders, because when I went to the police academy 24 years ago, this really wasn't talked about. But what I can say now is that officers that are currently going through the police academy, there's a whole curriculum on substance use disorders, and it's mandatory training yearly with the police department to talk about substance use disorders. So we've come a long way as far as the police department. And I just want to mention something that Carrie Ann said about business owners and educating them as well. We've also assisted in helping you with several businesses in the community that has experienced some problems, meaning maybe somebody's loitering in front of their businesses or using their restrooms. And like I said, this is a newly formed division, so if anybody hasn't met me personally, please feel come up to me and make a connection with me, because it's my goal to make sure that we're engaging with all segments of the community, and that is our business owners as well.
Hello, everyone. I'm a sergeant with the Winthrop Police Department, and I'm in charge of the outreach and follow-up methodology that we use with people in our community. Thank you for having me. And so the program in Winthrop is called CLEAR, and that stands for Community and Law Enforcement Assisted Recovery. The name is on purpose, and the structure of the program is set up purposefully as well. One of the key points that I want to share with you as food for thought for you to think about is in Winthrop, a uniformed officer searches out and tracks down a person that may be struggling with SUDS, mental health disorders, or both. And that person does something that's been referred to as knock and talk, right? So most of the time right now, that's me. And why a uniformed officer? I believe, and we believe in Winthrop, that there's a powerful reparative effect when a uniformed officer shows up and says, can I help you with this? And means it. And starts a conversation off by saying, look, I'm not investigating anything to jack anybody up or get anybody caught up in the law enforcement system. So that allows for the work to start shifting towards protect and serve everybody, right? With respect to businesses, I would say for all of us involved, we can't assume that the businesses know about the programs in our community. Small and mid-sized business owners are really, really busy people doing great work. So with respect to the police officers, we need to go out and meet the businesses and let them know. And maybe the community, the employees in the community can search out and ask for what programs exist around me as well. So as we've heard, a business is a microcosm of the macro. We know what's going on everywhere in our society, right? So that's also going on in our businesses. And so a psychologist back in the day, he came up with a hierarchy of needs, right? So there are base needs here, and businesses are helping meet those base needs by providing income for employees. If a program and a police department can assist in somebody keeping their job, we can kind of nip a downward spiral that can begin for somebody right in the bud, right? So that, I think, highlights how important this type of a meeting is, right? So there is something I wanted to also put out there as food for thought. The value of vulnerability. So when you assist a person right at the point of contact, right at the point of a crisis, you have access to the benefits of vulnerability. And what I mean by that is, I would say that an overdose situation is an intense situation for the person involved in it, right? So that makes them vulnerable and open to motivational interviewing, open to new suggestions and new thoughts that could lead them towards paths of recovery. I think it's really important to utilize police officers to try to get in as close to vulnerability as possible. To have a raw conversation, correctly, ideally, right? So another thing that happens with these programs and everything that you see here at this table, Lieutenant Amy O'Hara said we all know each other here, which is really important, is you have a community-to-community interlink. So when a Winthrop resident has an overdose situation or a mental health crisis in Revere, I can when a Revere person has it in Winthrop, I can reach out to Revere and ask them to find that person in Revere. They show up on their Tuesday outreach and say, hey, we heard you had something happen in Winthrop, and guess what? We're not here to lock you up. We're here to ask you if you need any type of help, and we have legitimate access to that help. I'd say that's a powerful thing. Very powerful, very reparative. Julia just recently gave me a person who lives in Winthrop who's having multiple situations in Revere, and we're outreaching to her. She doesn't even know Winthrop knows. But we're doing the right thing with that information. You see what I'm trying to say? This is powerful, this is important. Winthrop just had someone from Cambridge have a situation, looks like it's related to alcohol. I gave that person over to a lieutenant in Cambridge. So there's this net forming, and we need to keep this happening, and we need to push it out. Community to community, talking about helping people. The other side of that is community to community, trying to find high-risk individuals that might be causing violence and taking care of that appropriately as well, right? So this is the other side. Here's an example of an employer reaching out to a program. The employer happened to be in New York City, who knew about our program in Winthrop, who knew me personally. Called and asked about one of his employees. I was able to connect that employer to our team's recovery coach supervisor, who started guiding them on how to help the employee, because the employer did not want to fire the employee, right? And we just talked about how important that is. So what are we talking about here? We're talking about having a person focused with a recovery orientation, right? It's time for police to train in having a person-first recovery orientation to protect and serve, right? I think. So how do we do that? I think cross-training and exposure is important. Cross-training in different fields, not just criminal justice, and having experiences related to exposure, such as maybe having officers go to recovery coach academies, go to AA and NA meetings, meet people in recovery, right? So with respect to employers, I think you need the same thing. I think you need to cross-train and have exposure. Learn about addiction so that it's not so mysterious and scary, and possibly hire people within the boundaries of the law and treat them with respect and see about keeping them employed. So it seems to me that the time has come to make things personal within a professional boundary. Thank you so much.
Hi, my name's Chris Alba. I work with the Healthy Streets Outreach Program. I'm a harm reduction specialist, which means, you know, we always talk about everything and we talk about recovery, and that's the main goal, and that's not what I do. We engage with people, you know, we don't have expectations of them. The only thing is, like, we try and reduce the risks and harms associated with certain behaviors in these interactions. We build up their self-esteem and we give them some sort of self-respect and dignity. So what we do out there is we give out supplies. I walk around with Narcan. I work with the programs with the police in Revere and Chelsea. We say you're worth it, like you're good enough. The end goal isn't recovery, but that's usually where it ends up going, because they end up getting enough self-dignity that they want more and they want better things in their life. But like I said, that's not what our goal is. As far as engaging with businesses, I've been doing this for a long time. We're not where we need to be, but we are progressing. We are making progress. Just the fact that I'm sitting up here with two cops next to me and I'm not getting locked out right now is progress. So not yet. So 10 years ago, we were giving out Narcan, and we were having a hard time with a lot of law enforcement. They didn't know what it was, and they were trying to charge us for Class E's. Now I drive around with police cruisers with police officers, and we give out Narcan. So it's a process, and like I said, it's going to be the same process with the businesses and the business owners. Like Carrie Ann says, I've been going in and trying to talk to people. The clerks in these stores want the Narcan. They give us an email to somebody else. We never get responses back from them. And it's all about ignorance, and they don't really understand they fear that they may be held liable if someone does use Narcan and it doesn't work, and if there's anything's going to be any adverse effects. They really don't have the education around it. We need to like get around them and educate them. So now when I go to the businesses, and we do get a lot of businesses where people overdose in the bathrooms, I'll refer to Dan Cortez because he'll send an email with the Chelsea Fire Department, Chelsea Police Department address, and he may get a response to it. Whereas I'm just a kid with a stupid hat and a backpack full of Narcan saying, hey, let's do this, like, you know what I mean? And I refer Revere, I'll refer it over to Julia. They don't, they just need to, we have to get the right people in the room with another set of right people to have the proper conversations about why we want to do this. Like, people are dying in their bathrooms, and there may be a solution. And like I said, that's what harm reduction is. We're just trying to reduce the harms and harms associated with certain behaviors. People, like Dr. Wally was saying, people do not want to die. They don't know what they're getting. They're getting something different, and there's no need to die. There's no need to access to these tools. There should be no barriers to getting access to these tools. It doesn't promote. I drove here and I put my seatbelt on. That doesn't mean I was trying to get into a car accident. We're putting these things in there. These people aren't trying to die, but we're telling them we love them, we care about them enough that this is here. We don't want you to die. And usually that's what sparks the relationship with me, with the people I work with. I work with the most underserved population. Like, there's a whole catch base of the people that want to buy into the abstinence philosophy and go into recovery, and there's a ton of services out there for that. My demographic is the people that aren't there yet. It's pre-contemplative stage, and just a conversation with them when people are just walking by them and not even making eye contact with them is enough to instill some dignity and respect into them. And sometimes it starts with just a kid knocking. Listen, I care about you enough that I don't want you to die. Why does this kid care about me that much, and why does he not want me to die? What else can I do to better my life, Chris? And these are the conversations that lead to, you know what, this is what I need, and there's no expectations out of them with me, and we often build really strong relationships with these people that we work with, and that's basically what we do. So that's it for me.
Give me notes. Good morning, everybody. I'm Dave Batch. I'm the captain of the Chelsea Police Department. In charge of community services, every program that you can think of we have in Chelsea. I'm not going to talk about the programs. Dan's going to talk about the programs. What I want to talk about is that over the last few years, I think we all, with law enforcement, there's been a change, there's been an adjustment, a different mindset, recognizing a different approach to people suffering from addiction. It's not about enforcement, it's not about incarceration, right? We know people are suffering, it's a disease, and they need treatment. So that is our approach. It took us a few years to do it, and I always like to talk about how you have to do it and why we do it, right? So the reason why we're doing it is because it's the right thing to do, right? Police officers, our job is to help people. That is our main job. You ask any officer that gets on the job, one of the first things I ask them when I do the interview process is, why do you want to be a police officer? It's to help people, right? So that's why we're doing it, right? We treat people with respect, dignity, as Steve said earlier, and a police officer has to have compassion, and that's what it's all about. And that's why we made the adjustment, and it's just the right thing to do. How are we doing it? Over the last few years, I've done a lot of training for the Chelsea police officers. I brought the outreach workers into our roll calls, brought them into the station, introduced them to the officers, exchanged phone numbers. That's how you get it done. You have to get to know each other, you have to build relationships, and you have to understand why we're doing this, right? And you just have, that human element has to be, that barrier has to, you have to be on that barrier, you have to get over those hurdles. And we've tried to do that in Chelsea. Chris is in the police station 2 days a week. Kapik is in the police station, all the time. North Suffolk Mental Health. Dan will talk about our hub and core meeting that we have every single week with every different service provider. Because police officers, we do a great job of finding the problems because 24/7 we're up in the street. But we're not mental health experts. We're not addiction service experts. We're not, DCF. That's not our, we're police officers, and we can find the problem, but we just need help getting it to the right people, connecting to the right services to make sure people get the help they need and they can recover from whatever addiction they're suffering from. So I think that's the goal for police. I think all over the country now, that's the goal for police, but we certainly need help. We have our own programs that we've set up because there always has to be a structure in place. It's nice to talk about, we do this, we'll do that, but unless you follow that process, unless there's a structure, unless somebody's in control of it and making sure the work gets done, a lot of the stuff just drifts off to the side. So that's what we try to do. Dan will talk about some of the programs we have. We're helping core. We have Wednesday nights, Chris comes in with our outreach workers, and a new initiative, our downtown task force, where we do a lot of work. Thank you.
Hi everyone. So I just want to quickly talk about the evolution of how we got to where we are in Chelsea and how that was helped to change. So initially, the Mass General Hospital Chelsea Health Center created what was called the Community Leadership Team. That was a traditional coalition, and it was designed to bring all the powers that be to come together and figure out what we're going to do with this. I don't even know if it was called an opioid crisis at the time, but we needed to do something about our downtown area. So initially, to be honest with you, it had more of a let's fix this problem versus let's get these people help. So while that coalition doesn't exist anymore, the fruits of the labor do exist. And that started off with what we call our community navigators. Sometimes they get referred to as recovery coaches, but really what they are people that are in the streets 40 hours a week, sometimes into the night, and they engage individuals in the street. A lot of the folks that have already gotten to the pre-contemplative state because of the work of Healthy Streets, they guide them to detoxes. And it was great at the beginning because we were like, yeah, we got them to a detox. And Katie O'Leary's here who supervises those navigators. But we quickly found out is that they would just go back to square one. So we created what was a second contract, which is managed by Gladys Agneta, who's in the back here with our CAPIC team. And what they do is they provide basic supports, and that could be anything. It could be something as simple as a bus pass, just to be able to get from point A to point B, to food cards, to clothes, to all sorts of things that are helping people once they get out of that the detox facility, and even up to 3 months of sober living at a wonderful facility like the kind of Steve manages. And I also want to thank Stephen for being here, because it really puts us into that mindset of services first, and then also recovery leads to productivity. It's a wonderful thing, obviously. So the third contract the city entered in with also with CAPIC is case management. So we have two individuals that follow somebody once they get into a facility. Sometimes Section 35s do happen. So the goal is for them to establish relationships with these facilities, so when they get out, they don't go back to square one. So our goal is to have a pretty robust continuum of care, which is that initial engagement in the street, with the first steps all the way to long-term recovery, and then obviously back to the workforce. Some of the other things that we do is, but also a fourth contract is with Healthy Streets for outreach for sex workers, and these are individuals that Danielle works with tremendously. We just had a wonderful engagement yesterday with one of our harder to reach individuals. We do the wellness checks like you mentioned, and also every Thursday what we do is we get together. It's called the Hub. You might have heard about it. It's a weekly meeting where all service providers meet at 9 a.m. We introduce individuals. 65 to 70% of them are SUDS related. Individuals that are at high levels of risk. And what we do is we mobilize teams for quick interventions that usually happen within 48 hours. And the beauty of that is that the following week you have to provide an update. So if you said you were going to do something and you didn't say, it's going to be pretty evident at that next week's meeting. We also do the Downtown Task Force, which is more business oriented. The Chamber of Commerce is there. Property owners, business owners, individuals that are being impacted by the issue. We try to work proactively. We want to provide services to people, but we want to make sure that businesses have customers that are willing to come in. So it's a very interesting situation. And then some of the benefits quickly is that it's led through donation of determination of need money from Mass General Hospital. We now have a church on Broadway, 738 Broadway, where it's open Monday through Friday, 9 a.m. to 1 p.m. It's where individuals can go in, get a shower, get a meal, breakfast and lunch is served. Ruben, I don't know if he's still here, but he's the director of that program. And that was money that we were able to direct from Mass General to the church. It serves as a warming center whenever we need to open up. And it's served as a beautiful engagement point. Before we used to have to engage people on the street, they wanted nothing to do with us. They wanted nothing, maybe something to do with Chris. But these are people you're trying to convince them to change their lives in a terrible situation. But when you're at a church, and it's very similar to this setting right here, and you're eating with them, they just took a shower, and then there's a minister there, and it's a beautiful setting, they tend to make changes in their lives. And then one more thing, we just did our homeless count, and we found one person. Not that if you went out tonight you wouldn't find anybody, but that's because we've been able, through the hard work of Catholic and everyone else, we've been able to get everybody that's been, especially the Hispanic alcoholic men who sometimes get forgotten because we're all focusing on the opioid crisis. These are the individuals that are now accustomed to utilizing shelters. They're accustomed to getting their bus passes. They're accustomed to accessing resources. A lot of these folks are now in recovery. They're back at work. It's been wonderful. So I'll stop there. Thank you all for the great work that you're doing.
Panel would be happy to entertain questions. Yes, Karen.
Hi, my name is Lee Nugent. I actually work for the police department and also part of the hub group as well. My question, as a parent raising 3 grandchildren because of this disease, is when you do these, like I know on the hub we do this, in Revere, I get a lot of calls from families of the person, a substance abuse issue, looking for resources, looking for help. Do you ever reach out to the family and give them resources or tell them, what, because parents are the front line. They're the first, responder, if you may. And I know my daughter often tells me, you don't know what you're talking about. And she's right. In most cases, I don't. And I know the parents that I come across have the same questions like, well, that's all great and well, but I could use some help too. I could use some resources. Where do I go?
So when you say resources, do you mean like a printed list of resources?
We need support, like parent support, that go support.
Yeah, and not just that, but parents, educating parents on how to deal with this issue. They don't always know either. No. What to do or where to go or how to interact with the person.
Yeah. Yeah. So I'm gonna let Chris start, and I think Carrie Ann finish because they can both speak to what it is.
So basically, it's really important. Every time I engage with someone and the family's involved, it is the most important thing to get the family involved in the treatment and empower them to be able to help their children. Because if not, like my experience is, like my phone's blowing up 24 hours a day with someone with questions, and like there are organizations out there that are better equipped to help families, and we refer out. And not only do we refer out, because I'm a huge proponent of not just saying, here's a phone number, call someone, because it's very hard to do. We help them get there. We bring families to learn to cope, self-help groups, whenever we possibly can. It is the most important thing is getting the family the help that they need to, and I always describe it as like, I deal with mostly like people that are actively using, and they create this spiral, this tornado in our lives, in everybody's lives, right? And then they'll go in their room and they'll do drugs and they'll shut it off, and the whole family's still spinning in a tornado. And if they don't get help for themselves, they probably can't help their children. But I'm not a specialist in that, and I always refer out to like Learn to Cope and support groups. There's one in East Boston. There's groups in Revere, and let the family heal along with the person with them, and that way it's. I have relatives that use too, and I'll drop somebody off at detox 50 times. They'll run out the back door, and I'm like, all right, whatever. That's what we do. When a family member of mine runs out the back door, I'm out at 2 in the morning in the pouring rain trying to choke that person. So it's hard for somebody to deal with somebody that's really close to you, and I think I'm helping them, and I'm really not. And I know how to do this. I've been doing this for a long time. But when it becomes to a family member, sometimes we have to step back and say, you know what, like there's some professionals, can you let these people talk to you? And that's what we do. We talk to the people, and we let the family support groups help the families as well. We can't work with both.
Yeah.
And yeah, most of the drop-in center is utilized by parents. Anytime we have people coming in every week, it's the parents that are suffering, that don't know what to do. We do have a team that is at the drop-in center. We have Kim Hampton, she's the director of North Suffolk Mental Health, the substance use department. She runs a parent support group in East Boston every week. And so on Monday nights, I think it's 7 o'clock, Katie? 6 to 8. So, and it's a wonderful support group. It's been there for a long time, and the parents there support each other. I personally, because I know the difficulty of parents, you know, the stigma, people knowing their business, that type of stuff is really a big barrier. I physically will take a parent to a support group such as Learn to Cope. The Al-Anon meeting in Revere on Wednesday nights is all parents. It's like the whole group is parents. So there's a lot of support groups for parents if you utilize them. Some people are not interested in doing it in a group setting. That's when I'll refer them out to one-on-one, one-on-one a therapist that specializes in substance use. So those are the resources that we use right now. But we do on our drop-in night, we'll sit there for 3 hours and talk to a parent. There was a parent that came in last night. He was there for 2 hours. And he got some referrals out, but we also sat and engaged with him as well. So that's what we have.
Hi, my name is Jim Peake. I'm from Marblehead, Massachusetts, and I have a company called Addiction Rep. I'm a consultant in the rehab space. I'm going to ask a loaded question, and I don't expect many people to know the answer, but I'm going to try to answer it for you. So, does anybody know of the Bridge device?
Can you say that again, Jim?
Does anybody know of the Bridge device?
Bridge device?
Yes, it's a medical device that stops the pain from opiate and opioid withdrawal and all the related symptoms. And it's approved by the FDA.
Really?
So if you go to www.bridge-rep.com, you will see all the studies and all the information and all the articles.
Is it covered by insurance?
Not yet. Okay, that's regulations that Trump is trying to get rid of. It's going to take us 2 years to get coverage, to get our CPT codes. And right now it's $600 a unit.
When did the FDA approve it? When did it go on the market?
It went on the market about 4 years ago, but it got approved in November.
Okay.
So it's brand new.
So 600 for how long?
600. You wear it for 5 days. It's like a hearing aid. You put it on the back of your head, and it's got 3 percutaneous leads that go into the ear. It's kind of like electroacupuncture, but it's not.
That's awesome.
It was originally classified as electroacupuncture device, but my problem where I need everybody's help is getting this into providers here in Massachusetts. Because the healthcare providers, the Mass Department of Public Health, they're not interested. So I need help. From the community, I need to create demand from the ground up, from everybody in the community so that they know about this and they can ask their doctor to prescribe it, because we need a prescription to get people to use it. So.
And your consulting firm is based out of
Marblehead.
So there is an MOAPC, which is the Massachusetts Opioid Abuse Prevention Collaborative grant-funded community. It's like a regional grant. Lynn is one of those communities, and I know that they partner with Swampscott and I believe Peabody. I have the woman's information if you want me to
Thank you very much.
exchange. Yeah.
So I think this is a very good connection for you to multiple communities. Thank you, Julia. Thank you.
Thank you. Yeah.
Hello, it's me again, Cheryl from the Twisted Tea in Winthrop and Revere. And my question is for everybody. Through the past 15 years, we clearly have had opioid issues, both on the beach and also in Winthrop. And do you recommend Twist and Shake carrying a Narcan kit? If yes, where do we obtain it? And if you do recommend it, where can I have my management team trained? Thanks.
First, thank you. It's Cheryl. Thank you, Cheryl, and thank you for thinking outside the box and just the thought of having it on site, especially in that location, would be pivotal. So yes, first and foremost, where you would get access to it, we would be able to provide that to you. If you'd like, we could set up a training where or Carrie Ann could come in or Chris could come in and train your whole staff. They have an actual curriculum. It's the overdose education, naloxone distribution program. That there's a curriculum in place where they teach you how to recognize and respond to an overdose. They'll show you, they'll have a naloxone in hand and show you how to utilize it, and then everybody has to then become certified, or is it certification or train? Enroll them. But then it's within the state system that this person has been trained in naloxone, and then every time if you God forbid, had to utilize it, they would come back in and refill the naloxone for you free of charge. And we'd be able to do this training for any local business free of charge. So if you want to get Carrie Ann's information afterwards, we'd love to come in and provide that training for you.
And does Winthrop feel the same way? If I did the training in Revere, it would carry over to Winthrop?
So, yeah, I mean, both they and us in Revere and the public in Winthrop and the public health department can help you with that.
Awesome, thank you.
Ms. Burton, answer the naloxone question?
Yes.
Follow up? Okay, I have another gentleman, but this is a follow-up.
So I'm Christy, we're from Mystic Valley Elder Services, the two of us here, and we felt pretty important, it was pretty important in our agency, though we're not working directly with a lot of folks who are actively overdosing, the population that works there is at a high risk, just at the basis of their age and, not knowing where everybody's coming from, we thought it was important to have it there. So I guess my question is, we are going to get, in our agency, do you have to be trained to administer it?
Well, I mean, it's very simple. It's basically a mini Flonase. Anyone can do it. The more that you train in the overdose prevention piece is more important than the actual administering the knife.
Because there's some just, myths about what to do if you recognize an overdose, and they have all the appropriate information and the factual, insight around this that they can provide for staff.
And is the training free of charge?
Yep, it is.
Get trained. Don't. A lot of people think I just have Narcan. I feel safe. Then the person that needs to administer it doesn't know how to use it. So it's good to have it training. It's not just enough to have it and not be able to use it.
Can I say something about that? Yeah, real quick. You might think you'll be able to handle the stress that arises from seeing somebody going blue on the ground, but talking about it, seeing it increases the likelihood of you doing it correctly. When you have a full adrenaline dump, even though you gotta just open this packet up and spray it, you might drop it. And having an understanding that if I drop it, it's okay. A few seconds, it's okay. Just pick it back up. Take a deep breath, calm down. So that's why it's important to do the training,
We have a question over here.
So Dan, before you leave the room, I have a quick question that I hope you can answer, or somebody else. You talked to a national audience in December about a wonderful program in Chelsea. I think it was a day treatment program funded by MGH. I mean, it seems like you've almost created de facto reentry program, a wraparound program with your case managers, with CAPIC, and with this day treatment program. I just wonder if you could say 2 words about that program. It sounded pretty impressive.
Sure, I talked about it a little bit. It's at Church on Broadway. It's Luis Cristo. It's officially called the Sela Day Center, SELAH, and I don't know if he's gone, but it's managed by Ruben Rodriguez. He's a former navigator, and it's real simple. It's just 9 a.m. until 1 p.m. breakfast and lunch, and all the navigators go there. Chris and his team go there. They test there. There's all sorts of drop-in services that are being provided. There's a church. It's a church, so there's a ministry that happens. And it's a great way to really, I like to word the use stabilize, maybe that might be the most appropriate word, but it stabilizes individuals so they can, think clearly and think about what they want to do, employment and whatnot. I'll just give you a quick anecdote. So we have an individual that's still in active use, and the last time the captain and I engaged with her, she told us where to go, and it was chaotic, and it was just a very chaotic scene. The last time I saw her a couple weeks ago, we had some folks from the Department of Mental Health there visiting it, and I wanted her to meet them, but she told me, I can't talk right now, I'm in Bible study. So that's the kind of change, shift that a place like that can offer.
Thanks, and we can connect you with Ruben. Other questions? Well, I know we could talk for a long time. This has been a wonderful presentation by different panels. Yeah, Julia.
Chris did mention something about the businesses are sometimes worried that they'll be held liable. We do have a law in place, the Good Samaritan law, which protects people from any persecution. If you are carrying a naloxone, you're able to carry it. And prior to that, prior to this bill, people could get arrested for it, but it's completely safe, and the police are not going to arrest you for reviving somebody from an overdose. So I just want to make that quick point.
Thanks, Julia. I want to thank everybody very much, all of you who stayed right to the end here. It's 11-ish. So please give a round of applause for this panel. And thank you very much. This will be broadcast on cables, I think, of all three communities, two, and probably all three. And we'll be happy to give you any resources and connect you with any of the speakers. Thanks again.